First speaker I've got a great privilege to introduce one of my colleagues, Mr. Simon Knight. He's the Director of Thoracic Surgery at both the Western Hospital and also at Austin Health. And he's been at the forefront of surgical tracheostomy care now for many years, and a fantastic resource for us both at the Western Hospital and Austin Hospital. And he's going to talk about the early complications of tracheostomy insertion and care. So, Simon, I'll welcome you up to the podium.
Well, thank you very much. Thank you to the organising committee for asking me to speak here today. I guess as a perpetrator of this mischief that we call a tracheostomy, I do have to take responsibility for the complications that we are responsible for, and I guess it's very appropriate that I've been asked to talk about surgical complications. The earliest records of tracheostomies go back well into antiquity. And these were all mainly done as emergency procedures we imagine on the battlefield with bronze swords. And it wasn't until you get to the work of Hippocrates in about 370 BC that you see a critique of tracheostomy, and Hippocrates actually warned against the performance of tracheostomies because of, as he put it, inadvertent laceration to the carotid artery. And I guess he was referring back to those battlefield type tracheostomies. I hope a very different thing from what we're talking about today. This chap, and I've sought counsel on how to pronounce his surname, but I won't trouble your ears with my mangling of ancient Greek, was the first to be credited with the performance of a non-urgent or semi-elective tracheostomy. He did so in the face of a lot of criticism in the area. We can read between the lines. As well as the concerns of carotid damage, there was reported a high risk of infection and concerns regarding healing, since it required cutting through cartilage. And again, I guess this again relates back to the old battlefield tracheostomies. In order to find the first successful tracheostomy, and it's not clear what is defined by a successful tracheostomy, we have to wait until 1546. And in the period between 1500 and 1800, 300 and something years, there are only 28, again, successful, God knows what that means, tracheostomies recorded in the medical literature. So it's although well identified in antiquity, it's only a fairly recent development. Through the 18th and 19th centuries, it remained a rare procedure, and people were again fearful of lethal complications. And you've already heard the story this morning of the famous 1799 non-tracheostomy, where a recent ex-president died because someone was too afraid to do a life-saving procedure because of the potential for a life-threatening complication. And I guess you didn't want to be the person who killed the recent ex-president. By the early 20th century, the techniques had been well described. And again, you've already seen a photograph of Chevalier Jackson, so purportedly doing a tracheostomy in the backseat of a car. But the morbidity and mortality remained high. And it wasn't until the 1960s, with the emerging use of intensive cares and improvements in tube and cuff design, that it became a safer procedure. And of course, more recently, we have the confounder of the introduction of percutaneous tracheostomy, something which I'll talk about more later on. Surgical complications can usually be divided into three broad groups: the early, mid-term and delayed complications. So I'm going to focus on the first two areas, early and mid-term complications today, and particularly on tracheoinnominate artery fistulation. In order to establish my bona fides, if you like, why am I being asked to talk about tracheostomies? We provide a bedside open surgical tracheostomy service to the intensive care at the Austin Hospital, and have been doing so for a number of years. Our database, which records all of the thoracic surgical procedures done there, has some 1,200 odd bedside surgical tracheostomies that we've performed, and that's the basis of the stats that I'll be talking to today on our experience. As you can see, there were a number of deaths related to tracheostomy, but in fact these people all died of the underlying condition that earned them a tracheostomy, and we're proud to say that we've had no procedure related deaths in that time. The mortality figure, 20%, this is in keeping with the figures which range from the low teens up to the mid-20s in the literature. The technique we use is depicted here. I'll just go through this quickly. It's a fairly standard surgical technique, although the use of these pesky blue sutures that someone alluded to earlier on today allows us to stabilise the trachea for initial incision and insertion of the tracheostomy tube, and also, dare I say it, for later reinsertion in the emergent situation. The technique was described by Adrian Burke, who we have adopted as an Australian since he presented this technique whilst he was working in Adelaide. He is in reality a Scot, sadly, but we regard him as Australian. The morbidity that we record related to our tracheostomies is depicted there. As I reiterate, no procedure-related deaths, but we certainly have had bleeding as a complication of our surgical tracheostomies, and it needs to be remembered that our environment is ideally set up to be looking after people with significant coagulopathy in our intensive care. We have a very active liver transplant unit, and we're dealing with people both pre and post-transplant when their coagulation status is not yet fully stabilised. We have a cardiac surgical unit that seems to enjoy doing massive aortic procedures with the concomitant associated coagulopathy, and patients need hemodilution and anticoagulation for their underlying medical problems, and we'll be operating in the face of coagulopathy quite frequently. Despite that, the rate of bleeding requiring surgical re-exploration is quite low, only 0.24%. Infection rate is low. Dislodgement rates are real, and there is a number of re-explorations for equipment failure, cuff leaks, poor positioning requiring reinsertion of a different sort of tube. But overall, the complication rates are fairly low. This is the sort of thing that causes tube occlusion, and I'm sure you've all seen something like that where the patient's breathing through this tiny pinhole. The midterm complications are depicted there. We've fortunately had a very low rate of stricture formation, and again I'll talk more about a randomised trial that we conducted that actually looked in detail at that in the long term. Granulation tissue and non-closing stomas are fairly rare with us. We do not use the Bjork technique. One of our very novel complications, novel I suppose if we weren't the patient had it, was a maggot infestation. This sounds like something from the third world, but this was a patient with a anaplastic thyroid carcinoma which is fungating through the skin, and we were called to pluck the maggots out from time to time. There was one tracheoesophageal fistula that we were asked to manage. This was not one we had created. This was a unit in our hospital that thought to have their first whack at a percutaneous tracheostomy, having never done one before, having never been shown how to do it, and reading as they went from the instruction manual. And once the endotracheal, or the tracheostomy tube was in, there was a 2 centimetre hole in the back of the trachea which communicated with a 1 centimetre hole in the front of the esophagus. That was successfully managed. But I'm very proud to say that we have never generated a tracheoinnominate artery fistula. We have been involved in the care of a patient with a tracheoinnominate fistula that you'll see later on, a slightly different environment, a woman of mine who had had recurrent mucoepidermoid carcinomas of the trachea with multiple dilatations, multiple irradiations, who went on to have a total laryngectomy under the care of the ENT group, further irradiation and then subsequently spontaneous bleed. But you'll see more about her a little bit later on. But this is the entity I've been asked to talk about, and I have to admit, I have not had first-hand personal experience with creating this, but it's well documented in the literature, a communication between the innominate artery and the airway in the association with the presence of a tracheostomy. Fortunately, it's a rare complication, but it is devastating, and the outcome without intervention is universally fatal. So why are we interested in this at all? The last line gives that to you. It's potentially avoidable, and I think if we can find strategies for avoiding it, so much the better. Again, I think as you get older and greyer, you look more towards history, and again I look back towards history. The first report of a fatal tracheoinnominate artery fistula occurs in 1879 in a 5-year-old boy who'd had a tracheostomy for diphtheria. And at that time, diphtheria was the principal indication for tracheostomy, clearly something we don't see these days. By the mid-1920s, there was a very large series reported, 115 fatal post-trachea hemorrhages, and the innominate artery was the culprit in the vast majority of those. But it wasn't for another 40 years before the first short-term survival was described. These were always fatal in the past. It took another 4 years before a long-term survival was described. So in those days, common problem, nowadays a lesser problem, but still a devastating problem. If we look at the literature in modern times, it is rare. Most series report well under 1%, 0.6, 0.7, 0.1%, but the incidence is higher in children, and I'm sure our colleague from the Children's will confirm that. And in a survey of national survey of otolaryngologists in the US who are asked to report their experience with catastrophic post-tracheostomy complications, the tracheonominal artery fistula was the culprit in a quarter of those events. So it accounts for a large number of catastrophes with tracheostomies, even in the modern day. In this era, there are thought to be two mechanisms for tracheonominal artery fistula in the sort of patient population that we're talking about, the patient with an intact larynx who's having a tracheostomy inserted for airway management. And they are pressure necrosis to the low anterior tracheal wall and subsequent perforation of the innominate artery, or higher in the neck, direct contact with the tracheostomy tube and the naked innominate artery in the neck. The first mechanism is depicted here and is thought to relate to a couple of factors. One is high balloon cuff inflation pressures causing mucosal and tracheal wall ischemia, and or poor tube placement with impingement of a rigid tracheostomy tube against the anterior wall and just physical abrasion into the innominate artery. Excessive tube movement has also been described as one of the causative factors. Now, I was fortunate enough to work with the guy on the right-hand side of this slide, Joel Cooper. In his residency, he contracted tuberculosis, and when recovering from TB, Hermes Grillo, who's the other chap, set Joel to work trying to work out why people were getting tracheal strictures after being intubated with intensive care. And between them, these two worked out that it was high cuff pressures. They used to use red rubber tubes with non-conforming balloons. They had to inflate the balloons to high pressure to distort the trachea to get it to seal against the cuff. And these two gave to the world this entity, the high volume, low pressure cuff, which conforms itself to the trachea and does not cause tracheal mucosal injury. I'm aware from speaking to Joel that to this day he kicks himself for not patenting the idea. There were clearly other changes in tube design. The metallic tubes went their own way, and these plastic tubes with better angulation have largely eliminated that older style of TIF fistulation. We are, however, left with this problem of direct pressure necrosis of the artery in the neck. And two factors go to cause this. One is poor sighting of the tracheostomy tube, the other being an abnormality of the innominate artery itself. And you'd think, looking at that diagram, there's plenty of room between the cricoid and the innominate artery to get a tracheostomy tube in safely, and most often there is. And if you look at the sort of standard approach path here, the path is well away from the innominate artery and should cause no problems. If, however, you're cavalier and want to put your tracheostomy tube low in the neck, you can see that you're asking for trouble. You've now got your hard plastic tracheostomy tube rubbing against the every pulsation of the innominate artery. And people like Grillo argue that we should be putting our tubes in at or about the third costal cartilage. There was a passion for low tubes for a while because of concerns about laryngeal damage and stricture formation at the laryngotracheal junction, but I think this low tracheostomy tube's gone the way of lace-up boots. The innominate artery pursues a variable course, and it's an innominate artery like this that would tax any tracheostomist, be they percutaneous or open, to avoid. This is fortunately a rare situation. But there are variations. Now, each of these sagittal CTs are people that I have put a tracheostomy into, so this is a real series. This is the normal situation. One can imagine, however, that this is a somewhat more challenging tracheostomy to insert. You can see that the innominate artery now is up level with the sternal notch, And if you look closely, you can see that the cricoid is sitting directly on top of the innominate artery behind the sternum. And this would be a challenge for any tracheostomist to insert. You place the patient in the hyperextended position on the bed in the intensive care. Unfortunately, as the cricoid goes up, so the innominate artery goes up with it. And this requires special consideration to avoid damaging the innominate artery or placing your tube next to it. And there are variations in the normal. Here's a young man with a long segment of trachea in the neck, but the innominate artery is sneaking up into the neck. And in older patients, the tortuous, elongated carotid artery can meander across the front of the trachea for quite some distance. So one needs to be cognizant of where the innominate artery is when you're placing your tracheostomy. And we have a particular passion in our hospital for dealing with patients with aortic dissections. One of our surgeons has a particular expertise, and in that group with the hematoma and the surgery, the whole aortic arch gets translated up into the neck, and as you can see, there's the innominate artery projecting 3 or 4 centimetres above the top of the sternotomy. So what are our strategies for this sort of thing? If you were to you consider the normal tracheostomy path in a patient where the innominate artery is translocated cranially, again, you will be at risk. So is there a strategy? Well, the technique we use is when we identify the innominate artery to be at risk, we make a far higher approach. We dissect the thyroid cranially out of the way, and we go as high as we dare in the trachea, keeping a pad of tissue between us and the innominate artery. And if we're unfortunate enough to actually see the innominate artery, immobilise tissue and close it over the top of the innominate artery, tissue such as the strap muscle or mediastinal fat. Percutaneous tracheostomies. Is there an increased risk of vascular injury with percutaneous tracheostomies? As a surgeon who practices exclusively open surgical tracheostomy, I may be biased and I may perceive that there is a risk. And if I was to read the literature casually, there are multiple anecdotal reports of series of 2 and 3 patients with TIFs with percutaneous tracheostomies, and you think this is a shocking procedure. But there was an extensive literature review done over that period of time where they've identified 8,000 percutaneous tracheostomies, and in that group there were only 27 deaths from bleeding, and only 11 of those were due to TIFs giving an incidence which is quite acceptable down at 0.13%. So I'd have to stand back from my biased position and say, no, I think percutaneous tracheostomies are probably quite safe in that regard. I was surprised earlier this morning to hear this study, which I was one of the instigators of, described as Simon Knight versus the rest of the world. This was a randomised controlled trial trying to evaluate whether percutaneous tracheostomy was or was not different to open surgical bedside tracheostomy as we conduct it. And it was a well-constructed study over 4 years, and we had 100 in each limb, and I don't know whether you read this, but we found no difference in any of the parameters that we measured that were of significance, especially in terms of complications. And so I go on to say that in fact percutaneous tracheostomy is perfectly sound in the hands of people who've been trained how to use it safely and who take appropriate safeguards. The problem I have with percutaneous tracheostomies, you can just pick the pack up for the first time, having never ever done it, read the instructions and have a whack at it. That's what I would like to counsel against. I should say there was a statistically significant difference in the cosmesis. The percs beat me on cosmesis. I would challenge even the most enthusiastic percutaneous tracheostomist, however, to succeed in this particular case. You notice that the innominate artery is in fact in front of the cricoid cartilage in the neck, and this again was one that we successfully surgically tracheostomised. Another question I'm asked to deal with occasionally is the pulsatile tracheostomy. Is this a real risk factor? It seems to have gained traction in our hospital of recent. Does it pose an imminent risk of bleeding? It was first described a heck of a long time ago. And there are multiple anecdotal reports of the pulsatile tracheostomy preceding catastrophic bleeding. And a nice one from Davis and Southwick was back as far back as 1956, where they described 2 patients in whom they had bleeds and the tracheostomy was bounding away for the whole time they were in. The challenge is there are many causes of pulsation, and in patients in ICU with hyperdynamic circulations, the whole structures move up and down, and it's rare for it to be a problem, but if you're worried, I think it's very appropriate to investigate these patients with some form of imaging, and usually it's CT, in case we've got it wrong and we do have the tracheostomy tube too close to the innominate artery. All right, coming close to the end. Management. What do you do about these when they occur? And I think the first thing is to have a high index of suspicion. The patient who has a bleeding tracheostomy, you need to exclude this as the cause. Suspect it in every bleeding tracheostomy. And in essence, if the bleeding is profound, you need to stop the bleeding. Well, that's like saying water is wet. Clearly, if the patient's bleeding, you want to stop blood loss. But the other issue is that if they're bleeding profusely, they can drown. So you need to manage this. Your first strategy is cuff hyperinflation. You may be lucky enough to be in this situation where the hole is right by the cuff and you stop the bleeding. But otherwise, you're aiming to stop the patient drowning in their own blood. If, however, cuff hyperinflation does not work, then you stick a finger in. Now, the next diagram is very neat. It shows a very calmly placed finger in the hole, occluding the artery. There's something else about this, though. You'll notice the tracheostomy is not there anymore. So someone's had the cojones in a bleeding patient to take the tracheostomy out and reintubate them orally, and this would not be a calm and straightforward procedure. Getting a finger in beside a tracheostomy is a challenge. So I think this is very good, but how often you can actually succeed in doing this, I'm not sure. I think what's changed the landscape for managing tracheoinnominate artery fistulation is the advent of endovascular stenting. We've had experience with this when one of my colleagues biopsied the innominate artery doing a metastanoscopy, and we've got a few other examples of this. And here is a nice photograph in the literature showing a patient with a TIF with an endovascular stent in. This was a Japanese article, and they stopped the bleeding. And I'm sure this is very, very much the case. This is our own experience, and Dr. Warrilow, I'm sure, is starting to sweat and convulse here, because this was a patient he was intimately involved in. This is the woman I was describing before, who had a laryngectomy in the face of radiation and tumour, and she was bleeding from her neck. She went to the radiology suite where they deployed one and then a second stent because they hadn't quite fixed the problem, and they did control her bleed. Clearly it's a temporising manoeuvre. It's not great as a long-term fix, but it then does allow you to consider definitive repair in the cold hard light of day. And this is this diagram depicts the basic principles of definitive repair, and that is to say, don't try and stitch the artery. It's rotten. It's not going to stop bleeding. It's just going to bleed again. You need to interrupt the arterial supply on that side. You need to repair the hole in the trachea. You need to put some sort of tissue in between the trachea and the interrupted artery. And then comes the question of, do you need to restore flow to the brachiocephalic? It is, after all, feeding the right side of the brain. It would appear not always. In the young, there is quite a good cross-cranial circulation, and it's not absolutely vital. The experience that states that comes from the survivors of surgery for TIF. The average age of those survivors is 24. The average age of the patients who we do tracheostomies on is 65. So the survivors are a selected subset. I've never had to do this. This would be an absolute nightmare. Our patient, I must say, that Steve dealt with, survived for another 5 months. She elected not to attempt definitive repair, and she lived for a useful period of time. So I would encourage that. So in conclusion, this is a rare complication, universally fatal if you do nothing, a high mortality if you do something. So the best strategy is to avoid it, and hopefully I've already given you some ways of doing that. And there have been several changes over time which have led to the reduction in the incidence and better management, and those are improvements in equipment, improvements in technique, and finally, as I say, endovascular stenting, I think, has been a big step forward. Thank you very much.
So we've got time for a question. David?
I would make a comment, which is for this audience, mostly non-physicians. Probably somebody in this room will stumble on one of these once in their career. And if you're not used to sticking your finger in people's bodies, the very first thing to do is put them in Steve Trombelenberg so they don't drown.
Yeah, that's the first thing, don't drown. Yeah, exactly.
That's something that you can do even if you're not comfortable.
David was just mentioning you can put them in a steep Trendelenburg position so they don't drown in their blood.
Thank you very much.
Thank you, Simon. So we're keeping on track with complications and how we might deal with it in the clinical setting. And I'd like to reintroduce to the stage Haytham Cooper, who did a fantastic speech/sales pitch this morning. And he's going to talk about the ENT surgeon's perspective with the paediatric complications. And then also our colleague from the Children's Hospital, Joanne Harrison, who will talk about the respiratory consultant perspective with regards to complications in the paediatric population. So, Haytham, come on up, and Joanne.
Team approach, healthy cooperation, you know, that's what we like to see.
Multidisciplinary care.
Yeah, huh. Well, yeah, but it starts off continuing the very surgical theme from that previous talk. And no apologies for that, of course, because I am a surgeon. I work in Glasgow in Scotland. This is Glasgow University, 1541. It was first opened its doors, and it's changed its bureaucracy very little since then. So this picture, actually, I dug out for this talk, and this impossibly young-looking person here is actually me, and this is me doing my very first paediatric tracheostomy, and this was about, the best part of 20 years ago, about 18 years ago, I think, when I did that. And the procedure that I learned at that point is very different to what I do now, and it's kind of evolved a little over the years. Because I've spent time with people who are cleverer than me and show me better ways to do it. But the procedure that I started was quite a standard and perfectly reasonable technique with a nice big wide horizontal incision and a bit of tissue dissection and stuff, and retractors everywhere. But it's changed a lot. And it's changed because of an awareness of complications. And when you're a trainee, you learn lists of things like this. Early and late and blah, blah, blah. And you also have this idea in your mind that you're training to be a surgeon, and that means you learn how to do operations. And that's the important bit. And it is important, obviously. But as I get a bit older, I'm kind of aware that actually the operation is actually in many ways the easy bit. And it's the decision-making that goes around it, which is the stuff that a lot more difficult to learn and which I'm still learning now. But that's all about the decisions about who you operate on and when and where and how and all the aftercare, and you begin to realize that actually most of that involves other people, and it involves relying on them to get you good outcomes, relying on your intensivists and your anaesthetists and your nurses and your therapists, and actually the only bit of any of this that is fully in my control is the operation. So that's the bit I'm going to talk about. That's the bit that's in my hands to change on my own. I'm going to talk about the early complications here, some of which relate primarily to surgical technique, and some of which relate primarily to how things are cared for in the immediate post-op period. I'll talk very briefly through the surgical technique and what I do, and then a little bit more about why I changed, and about the nature of evidence, and on. But this is something that I picked up from reading a book from an astronaut, because I'm a space geek, and it was about training as a US Navy test pilot. And it says when you're in a massively stressful situation with a huge information overload at any given moment, what they're trained to do is to stop and think, well, what is the next thing that's going to kill me? Because that's the thing I'm going to focus on. And then when I've dealt with that, what's the next thing that's going to kill me? So in surgery, we have the nice advantage that it's not me that's going to die most of the time if I get it wrong. But what's the next thing that's going to kill the baby in front of me? And that's what I go through with my trainees, okay? At this stage in the operation, what's the thing we need to do at this point that is likely to be the life-saving thing? So, if you look through that previous list about surgical early complications, and about surgical technique and the complications that relate to that. The way to avoid those in many ways is to make life easy for yourself and put yourself in a situation where the operation appears to an onlooker to be extremely easy. Okay? And we do occasionally get chat from our ICU consultants saying, actually, do we have to move this child to the operating theatre? Can we not just do the tracheostomy in ICU? That's standard practice in adults. We have never done that, and I'm not keen to ever do that. I like to do the tracheostomy in the operating room because I've got good light, optimum position, and everything looks easy, and everything is quick, and it goes easily, and it goes well. If I start doing them in ICU, then I am making life more uncomfortable and more difficult for myself. I have a suboptimal light, suboptimal position, and one day I will regret that. So I haven't done it yet, and I'm not planning to. So we give a good position, good light. We excise the subcutaneous fat so that we don't have to use any retractors. Just take out a little plug of fat and you're right on the muscle. Palpation as you go so that you avoid the carotids. And these are the things that make the difference. I do use stay sutures around the third ring to help tube reinsertion if they come out early. I put stomal maturation sutures in where I stitch the trachea to the skin so that it becomes very difficult to put the tube in the wrong place, becomes very difficult to create a false passage, and very easy to put the tube back in even on day one. And I think they're hugely life-saving. We never use Velcro tapes, always use cotton tapes because they cannot be undone, snapped or pulled out, whereas Velcro, even a little baby can get an arm underneath and inadvertently undo the Velcro if you're not watching. And so these are the things that are within my control, and these are the things that I do. The final thing we do is before we leave the operating room, we go through a tracheostomy checklist where we make sure we've got all the right kit and everything has been done right and documented before we go along to the ICU. And am I going to stand here and tell you that I've got top quality randomized controlled trial evidence behind each of these things that I do? And of course the answer is no, I'm not going to. And what is the nature of evidence for this? What is the evidence that's persuaded me to do each of these things and change my practice? Well, one of my pet hates is hearing people say, oh, well, we always use Velcro tapes and we never had a problem, or something along those lines. We always do this thing and we've never had a problem. Because one reason is that, of course, your practice is extremely safe, but the other reason why you've never had a problem is you just haven't had a problem yet. And the nature of what we do is that, particularly for children, you actually do very few tracheostomies. The children have them for a very long time, but each individual surgeon will, over the course of a career, have very small number of properly catastrophic complications, okay? And so you may have worked for quite a few years without having had a catastrophe. It doesn't mean there isn't one hanging around the corner for you. And it does mean that you absolutely have a responsibility to listen to the catastrophes that other people have had, because yours is just waiting for you. And yes, you may have had a nice run of a few years without a problem, but it doesn't necessarily mean that the thing you're doing is the safest one. So we have to look at other people's complications and make changes on the basis of what is really anecdote rather than evidence, Catastrophic events are rare. They're not rare enough. They still happen. Every series has them. Every published series has at least one death from tube occlusion. Everybody knows of a catastrophe that's happened. So they're not rare enough because they should be never events. They should never happen. And that's what we should be aiming for. So the anecdote for me is listening to other people and seeing what problems they've had and the catastrophes that they had. I haven't had one yet, but it will come. I do everything I can to make sure that it never does. Stay sutures, for example. Stay sutures. I was taught to put in stay sutures, and I've spent the best part of 20 years putting in stay sutures. And I spent the best part of 10 years thinking, why the hell am I putting these stay sutures in? I've never actually used them. I don't know anyone that's ever used them. Bloody stay sutures, why do I put them in? And I spent 10 years moaning about that until last year, when, actually on ICU, a very informative case actually, I put in the wrong tube, okay? And I hadn't checked it properly, and I put in the wrong tube and it was too small. And we went to ICU and there were problems ventilating the child, and I realised I had the wrong size of tube, and I realised that 2 hours post-op I was going to have to change the tube. Now actually, because of the stomal maturation sutures and a general cockiness, I thought this is not going to be a problem. So I took the tube out and I couldn't get the other one in. And no, it's fine, because I pulled up on the stay sutures, and yes, they are fantastic. They are life-saving. And for the first time in 20 years, I thought, actually, I am so glad that I put those stay sutures in every single case, right? And a randomized controlled trial is never going to show you that, okay? You're not going to have that kind of systematic review evidence that showed that stay sutures save lives, okay? And probably on that day, I would have got a tube in by some other means, and probably the child wouldn't have died. But actually what happened was the whole thing just took a couple of seconds, and the nurse with me hadn't realised that my blood pressure had gone through the roof and my pulse rate was 200. I just had a little moment where I thought, oh, oh no. And then I thought, no, hang on a minute. Stay sutures, pull up, there you go, fine. And that kind of thing is, you're never going to capture that with a research project, are you? You're never going to have a randomized control trial that tells you that. You're never going to have evidence for that. But what I've got is I've got a firm, deep and abiding conviction now that stay sutures are the thing to do, because they take 10 seconds to put in, and once every 10 years you will not have a coronary event. So that's my evidence for stay sutures, okay? Stomal maturation sutures. There is actually published evidence looking at things that can be measured, and looking at things like long-term fistula rate and stenosis and blah, 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 blah. And there's studies, they're not randomized, but the studies showing that actually complication rates don't seem to be any different, which I take to mean that stomal maturation sutures don't make things any worse. But I've got loads of experience of changing tracheostomy tubes in the first week, and I can tell you they are genuinely revolutionary, and they just make it so easy. So how do you measure ease of tracheostomy tube change? How do you measure surgeon comfort during change of the first tracheostomy tube? It's very difficult. There isn't an official validated rating scale for that. Difficult to produce a trial on that. Might be possible to do, but I don't think anyone is really going to do it. So I'm just going to go off the fact that actually my experience is that they are hugely, hugely successful in making early tube changes safe. So that's the nature of evidence. Velcro, what's the evidence for my deep and abiding hatred of Velcro fasteners for tracheostomy tubes, or death straps as they're known in my hospital? You know, I often get the nurses, oh, but the skin's breaking, can we not put a Velcro? Oh, you want death straps? Have you filled in the death straps application form? So, and we actually use Velcro all the time. We use it for the older children who are cognitively aware of what's going on and able to understand the consequences of pulling their tube out. But for children who are not old enough or cognitively able enough to understand the consequences of pulling their tube out, and who could inadvertently pull a tube out if they pull hard enough or get an arm stuck or something, I personally don't think they're that safe, so I don't use them. And why? Because I know of 2 children in London who died. Right? Now, it's not happened to me. I don't want it to happen to me. I'm not having that happening in my personal experience, if I have anything to do about it, because I know it's happened to other people, and that for me is enough evidence. Okay, yes, you could randomise 1,000 children, but I mean, who's ever going to do that? Who really is ever going to do that? And you know, how many children would you have to randomise to death straps? So, Mrs. Jones, your child's been randomised into the death straps category. Just sign the consent form there. So, I personally don't see that trial ever happening. But for me, I don't think we need to. I think we know that children have died because they had Velcro tapes and they got their arm stuck and they pulled the tube out, and that was enough. That was all it took for that child to die. I know that has happened. I don't need any more evidence, okay? So that's the nature of me. And the checklist, that came about from that case I was telling you about where I put the wrong tube in. And that was down to my own laziness and stupidity in not checking. So now we actually have a piece of paper which has a list of, you know, there's a tube and the spare tube and is the introducer there and blah, 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 blah. And actually that has been a genuine innovation on our part, which I would encourage everyone else to have. We now have the checklist for all our trachees before we leave the OR, and it just makes you check. And it is, you know, it's such a simple thing. It's a piece of paper that saves lives. So I'm really sold on that. My old boss gave me a big stack of slides from the 1970s. So I love wheeling out the old tracheostomy slides from the 1970s when nurses, dare I say it, looked like nurses. And because what we get onto now is we get onto the fact that those things that I do during the operation, they make me feel better because they're things that are within my control, and there's the easy, low-hanging fruit for me. But actually the big thing that makes a difference in the safety of tracheostomy tube care is stuff that is not entirely in my control. It's stuff where I have to actually, unfortunately, talk to other people. And it's things like, where will the child be nursed? Who will nurse the child, and who is that person, and is he or she adequately trained and confident in tracheostomy care? And, you know, what are our protocols for tube change? And I'm not going into why we do this, but we do. You know, how often and what kind of tube and all that stuff, that is, in many ways for children, much, much more important. When you look at catastrophic events, most of them occur after the first week. Most of them are airway events, and they're preventable with better education and procedures. And, you know, the in-hospital deaths that do occur, the vast majority for the underlying disease. So in children's practice, where you're doing a small number of trachees, but they're going to be in for a long time, actually it's all about their care, not necessarily on the day of surgery. It's the stuff in their hospital stay and their community stay. We can argue about whether complication rates are the same for adults or children. There's some papers that say that they are. My gut feeling is probably that complications are more common in children at the time of surgery, and certainly in the community when they're at home, because they have the trachea for so much longer. So they have much more opportunity for things to go wrong. So I think actually, yeah, there's things we can do in surgery and they're quite easy to do, but the real things that make a big difference are actually the innovations we have in team-based care and protocols and training, which we've been saying all day, but it leads nicely on to what Joe, I hope, is going to say about the physician's view of care. So there's another, check the wallpaper, another one of our 70s photographs. It's all about education and training and protocols. So that's all I was going to say about the surgeon's view, and I'm going to hand on to Joe. Thank you.
Well, thank you, Haitham. So just before I start my talk, a few words of explanation. Haitham very kindly put up his first slide with a picture of Glasgow, and although he works in Glasgow, he is not Scottish. That is not a Scottish accent. This, in fact, is a real Scottish accent, but I no longer work in Scotland because the rain just proved too much for me and the cold weather, so I relocated to Melbourne and have the privilege of working now in the Royal Children's Hospital just up the road from here, so that explains the accent. Hopefully you can still understand me, even though I don't have as posh an accent as Haitham does, but hopefully you can understand me okay. Now, I've made an assumption that the majority of people in the audience actually predominantly work with adult patients with tracheostomies, but that may actually be completely incorrect. So perhaps just for my benefit, would those people who predominantly work with children put their hands up so I can get an idea? So it's a reasonable percentage, actually, which is surprising. So a lot of this then will be very familiar to you. So we've heard a lot about tracheostomies, particularly this afternoon. We've heard about tracheostomy complications predominantly in the intensive care setting and in adult patients. Typically, however, the patients that I look after are somewhat different from the patients that we've heard about so far, but in some ways they're the same. What's happened over time is that young patients who require tracheostomies have become an increasingly complex group of patients who often don't have single organ disease. They often don't have one medical problem. They often are not looked after by one single specialty. They're often looked after by multiple specialties with input from multiple people. And also the majority of these children are very young. They're under 12 months of age. Now, when I was at medical school and started learning paediatrics, there was a very everybody said children are not small adults, and you've probably heard that expression before, and it is true, children are not small adults, but I like to tell my medical students that they're not actually alien species either. You know, they do have some overlap with the adult population, but I think that when we compare children to adults, and particularly thinking about tracheostomies, you know, children, the procedure is more technically challenging, I imagine. I'm not a surgeon, but gee, you've Haitham, who's clearly wonderful, so very talented surgeon, and you need people like Haitham when you have very small children that require the surgical procedures done. There's quite a lot of literature to suggest that they do have more complications and that they have higher levels of morbidity and mortality. In the previous talk, we heard about the increased complication rate of anormal fistulas in children, and that's been reflected in a number of other complications as well. And in addition, the younger you are when you have your tracheostomy, the more likely you are to have a complication. And given that the majority of our patients have their tracheostomy in the first year of life, therefore it's very likely that they'll have more complications. So when we think about why children require tracheostomy, well, the reasons for that have changed quite significantly over time. So historically, it was due to acute airway obstruction secondary to infections. Upper airway obstruction is still in most series the most common reason for requiring a tracheostomy, but now it's more related to complications such as subglottic stenosis, particularly in the neonatal population, some of the complex craniofacial syndromes, and then conditions like tracheomalacia. But increasingly children are requiring tracheostomies because they fall into the group that are known as technology dependent. So these are children who are requiring long-term ventilation for survival. So these are not children who are only undergoing ventilation in an intensive care setting, but these are children such as Erin talked about this morning in her talk when she was describing her son Will, that are going to go home and be ventilated via tracheostomy, often for the rest of their lives in the home setting. And these are the sorts of children that I would be involved in looking after. So why has a paediatric respiratory physician been asked to give this talk? I mean, most of the talks you've heard so far have come from intensivists or surgeons, and you're probably thinking, well, why is she standing up there giving this talk? Well, in my institution and another number of institutions, you have people like Haytham who might come in and do the procedure, and then they'll do the first tube change, and then they'll say, there you go, Joe, here's the patient. They're going to go home with this tracheostomy, and you can look after them for as long as need be. So I have a very active role in looking after patients with tracheostomies, and I look after them through their stay in hospital, and then the majority of our patients actually will then go home with a tracheostomy, which is somewhat different from what I believe happens in the adult population, where many people are actually decannulated within that first admission. In fact, in paediatric practice, the majority of tracheostomies are done in children who will then go home and have that tracheostomy in situ for months, years, and potentially their entire life. And as I said, these are very complex children, so it involves the coordination of a number of different teams, a number of different specialties, to try and deliver optimal care for these patients. And physicians are known as thinkers and talkers, and surgeons are known as doers. So as Haytham said himself, he doesn't like to have to talk to other people, whereas I love to talk to people. So I'm quite happy to have to talk to surgeons, delighted to talk to nurses, delighted to talk to speech therapists, physiotherapists, the entire group of people that are involved in looking after this patient. Given that the majority often of the patient's life with a tracheostomy will occur at home, then engaging the people who are going to be involved in caring for that child at home early on is really important as well, and aids in the management and prevention of complications. So coordinating of the care of that child when they're at home, and then also in their social environment, so when they go to school or when they go to kinder, is also a very important part of my role. So when we think about complications, this is where there's a lot of overlap with the adult patients and with the adult literature. Because as I said, children are not alien species, so the complications are very similar. But the complications reported are quite high, and I guess partly it depends what you define as a complication. So we've heard a lot about catastrophic complications, and they certainly do occur in paediatric practice, but what also happens is what might be regarded as many people in this room as a more minor complication, but yet for the family is still a very significant event, and for the patient potentially a very distressing event. If you look at paediatric series in the literature, complication rates are reported up to as high as 77%. In my own institution, one of my nursing colleagues, Sue Ellen Jones, and some nurses did a review of tracheostomy patients in our institution over a 6-year period, and they reviewed all the notes and looked particularly at the complication rates. And again, this is where we differ a lot from the adults in terms of the numbers. So, over a 6-year period at a major paediatric institution, there were 97 patients over that 6 years who underwent tracheostomy. Now, for those of you who work in adult institutions, you're like, oh, that's a month's worth of patients. The numbers are quite significantly different. But you can see listed on the slide there the sorts of complications, and I'm sure that you'll recognise these. These are not complications that you've never heard of. And so I probably won't dwell so much on the individual complications because we've heard quite a lot of talk of them so far. But very sadly, and catastrophic events do happen in paediatric practice. And certainly my own very early experience as a consultant, I vividly remember the first patient of mine with a tracheostomy who died at home of a tube occlusion. That is not an experience I ever want to have to go through again. And I'm sure that no one in this room wants to have to go through an experience like that, or help a family through an experience like that. Fortunately, it's rare. And in our own institution, for our own series, it was 1% of deaths were related to tracheostomy. Patients with tracheostomies have a higher mortality rate, but as we've heard in previous talks, often the cause of death is not directly related to the tracheostomy. But when it does happen, it's the same problems that you see in the adult population due to blockage or accidental decannulation or malposition of the tracheostomy. The key thing about these rare events, as we've heard a number of times, is that they are preventable. Probably the most common complication, however, that I would see in my practice is of infection. And again, the rates of infection in the literature are very variable, and I think there's great differences in terms of how infection in a tracheostomy patient is actually defined. If you've got a piece of plastic in your neck, it's a foreign object. Bugs like to grow in foreign objects, so it's very common to actually grow a bacteria from the tracheostomy tube. Does that mean the patient has an infection, or does that mean the patient just has the tracheostomy tube colonised by that bacteria? And the sorts of bacteria we see are usually Staphylococcus aureus or Pseudomonas aeruginosa. So in our series, when we looked at infections, we defined infection as an increase in symptoms associated with a positive culture or presence of neutrophils. And this is a very common presentation of patients I see who are out in the community where the mums are phoning, or the dads, are phoning me up and saying, there's just massively increased secretions, I'm suctioning every 5 minutes, I've been up all night for the last 2 nights, help, I can't keep doing this. And then, how do we respond in that situation? We get the child through the infection, everything's fine, there's not a catastrophic event. But for the parents, it's a few days off work, it's loss of sleep, it's a very bothersome and significant complication for that child and family. Tube occlusions, though, they're a potential disaster. They are more common in children. We use much smaller cannulae, clearly in children. We typically use single lumen cannula as well, and this makes it more likely that the tube will block. If it's not detected, it can lead to an anoxic brain injury or mortality. But I've also sat in clinic and heard parents come and say, oh yes, I was working at home and a little 2-year-old came up and tapped me on the leg and was blue, and I just think this parent is calmly telling me this has happened at home. So I just suctioned him and then everything was fine. And I'm like, oh my goodness. Our parents are dealing with these issues at home on a regular basis. There's a lot we can do in hospital to prevent them happening, and there's a lot we can do and a lot of advice we can give to the families to try and prevent them happening at home. But certainly a lot of the key drivers we've heard about this morning and this afternoon through the Global Tracheostomy Collaborative are very pertinent when it comes to trying to prevent tube occlusions. We need to have institution-wide protocols. We need wide education of both the nursing staff and medical staff and allied health staff who are going to be responsible for caring for these children with tracheostomies. But we also need to provide that extensive education to the parents who are going to be at home looking after that child day in, day out. Any carers that are going to be involved in looking after that child day in, day out, and are going to have to be able to respond in a timely fashion if the tube blocks, if the tube comes out. They're not going to be able to come 5 hours from the country to get to the children's hospital if the tube blocks. They need to be able to suction that tube, change that tube, deal with that emergency. So we need to be sure that we're providing that education to enable these families to cope at home. Stomal complications are also common in our patient group, and although less serious, again, can be quite bothersome for the child and for the family, particularly if they lead to bleeding. The parents don't like to suction and have blood coming out of a tracheostomy tube. Even if it's a little bit of blood, that's not something that parents like to have to deal with. And if they're not if the granulation tissue is not dealt with, it can lead to more significant complications. And on occasion, we do need to call in the cavalry, and there we have people like Haytham to come and help us. Complications can arise even after we manage to get the tracheostomy out. We do aim to decannulate our patients wherever possible, and lots of complications can still occur, unfortunately, even after the tracheostomy has come out. We know that in children, if the child is very young when the trachea goes in, or if the trachea is in for longer than 12 to 24 months, it's much more likely, that there'll be a persistent tracheocutaneous fistula that may have to be dealt with surgically. So again, we sometimes need the ENT surgeons. But there's quite a lot of additional complications that perhaps are less well defined in the literature, particularly in young children who are developing speech. Not being able to develop that speech in that young period of life can have significant effects on their long-term ability to attain speech and to communicate. And that cannot be overemphasised, that how much that will impact on that child and that family if they have impaired communication. They may end up with some tracheomalacia, which can cause some longer-term problems for the child as well. Aspiration pneumonia is another complication that we see, and also some necrosis of the skin around from the actual tracheostomy tube and the flanges. Again, something that's not well discussed in the literature, but it's very pertinent to my patient population, is the complications that arise for the family. We're asking these parents to be not just parents to these children, but to be technicians, to be doctors, to be nurses, to be primary caregivers, to deal with that blue child tapping them on the leg because their tube is blocked, to deal with the sleepless nights where they're up suctioning their child every 5 minutes. It completely changes what the relationship that the parents have with that child, and we can't underestimate that. It has an impact on the siblings. You know, if you've got a younger sibling or an older sibling that mum and dad are constantly having to suction and or they spend a long time in hospital, that affects the siblings, affects the whole family functioning. The child might be in hospital for a prolonged period of time. The parents have to take a lot of time off work. That has financial implications. It has social implications. A lot of our families talk to us about how socially isolated they feel because they might not find it easy to go out and about with their child with a tracheostomy. Parents often lose their jobs because of the absences they have from work. So these are complications that, these are not well documented or studied in the literature, but they're very real for the patient population, certainly, that I look after. And I'm sure they're real for the families of adults with tracheostomies as well. So in conclusion, although tracheostomies are rarely performed in children, the children that do require this procedure are generally a very complex group of patients that require input from a number of different specialties, a number of different disciplines. They are subject to complications. Those complications can be life-threatening, and for those complications, they are often preventable. And we do have a responsibility as carers of these children to put in place processes within our hospital and within our management of these children to prevent these complications. The complications can lead to significant morbidity, and the only way to really manage a child like this successfully is to involve a multidisciplinary team. So sorry, Haytham, you are going to have to keep talking to other people who aren't surgeons. And really, given that this is such a small patient group, the way to improve practice and to know what works best is to collaborate. And that's why meetings like this and organisations like the GTC are so vital to the future health and well-being of these young patients. So thank you very much for your attention.
So the next session is a combined session. Karen Dettering will be talking, but before I formally introduce her, I might bring the expert panel up as well, so that after Karen's talk that we can throw to them. So I think Nasir, Prue, Christy and Linda are going to come and take a seat up here, and Stephen will be moderating that. The first component of this session is a talk by Dr. Karen Dettering. Karen is both an ethicist and a respiratory physician, has been a worldwide pioneer in respecting patient choices. So this session is about bringing it back to the patient, which is the major focus of today. And Karen would lay claim to being one of the very few people in this audience that has had their paper quoted by Barack Obama in the US Senate. So she's been doing some amazing research, and I'd like to introduce Karen. Thanks.
Thank you. So I'd actually like to thank Tanis and the organisers for inviting me to speak here today as well. I've just got to, yeah.
Where are you? There we are.
Yeah, lucky last. I'd also like to thank everyone for still being here late in the day. So what I'm going to do is just spend 10 or 15 minutes just sort of running through a little bit. So basically, this is the outline. So I'll give you a little bit of sort of my view on the ethical outline to medical decision making. And then what I'm going to do is present a case, Mr. M, to sort of so that we can reflect a little bit on how this actually works in real life. So as you may or may not be aware, one of the things that I spend a lot of my time doing, so the Respecting Patient Choices program is an advanced care planning program, and this is something that I'm sure most people here would have some awareness of. And simply put, it's really a process of planning for future healthcare whereby the person's values, beliefs and preferences are made known so that they can guide future decision making for if that person reaches a point in the future where they can't actually actively participate in the decisions, either because they're unconscious or too unwell or whatever. And essentially it's based around a number of ethical principles around autonomy and informed consent, around benefits and non-maleficence, and also around dignity and other things as well. And we could have a whole talk about that, which we're obviously not going to do. And advanced care planning essentially assists the person to select and prepare a substitute decision maker, and ideally to create an advanced care directive reflecting their goals, values and beliefs, and any specific wishes they may have about their future health care. But to be effective, advanced care planning essentially needs to meet similar standards to the process of informed consent. So the person who's making future decisions needs to understand the selected possible future situations and choices, be able to reason and reflect about what is best, and to be able to discuss these choices and plans with those who might actually be then the people making the decisions in the future. And you'll see that some of this becomes relevant when we talk about the patient later. This is the famous paper, and I'm still waiting to be invited to the White House. Probably not going to happen. But you might sort of think, well, so what? But there's a lot of emerging evidence. In fact, the field of advanced care planning is a very growing literature field at the moment. And just in a nutshell, there's a lot of evidence now. Advanced care planning improves care, including end-of-life care. It improves patient and family satisfaction with care. It reduces stress, anxiety and depression in surviving relatives, and this is sort of how I got into the area, because in my early days as a respiratory physician and working with motor neurone disease, it struck me quite early that when we got the death wrong, it was dreadful. Not only for the patient, but for everyone that went on afterwards. And we, in the motor neurone disease field, you're often caught up with relatives afterwards. And it struck me that we've got to be able to do this better. And it was sort of a lot of my motivation for getting involved was around the survivors as well as the person with the illness. It's also been shown to reduce moral distress among healthcare providers. And this is another thing that I think is really important in sort of my time working around is, again, when we get this right, the healthcare team are happier as well and they turn up to work. And I think that's really important as well. And also in sort of modern society, I think cost issues become relevant, and there's evidence, emerging evidence, that it reduces ineffective and unwanted costly care at the end of life without increasing mortality. So it's not actually just a way to bump people off. It's actually doing something different to that. And there's a number of studies now that show that it probably doesn't increase mortality. The other thing I just wanted to touch on is medical futility, which isn't a word I particularly like, as you'll see in a moment. It's a bit hard to define, but at least in most modern places where medicine is practiced, it takes precedence over autonomy. So there's no obligation to provide a futile treatment. And it's also important to recognise that not only is there no obligation to provide it, but it may actually be harmful. So it may actually prolong the dying process, or it may increase suffering and pain for the individual. person, but also potentially for the family as well. And I think our role as healthcare providers is first to do no harm, and hopefully along the way to do some good as well. Simple, but I think how we define futility is part of the problem, part of the reason why I find not so keen on the actual terminology. The concept's good. And if you think about it, it's really talking about something that's ineffective or useless, but how do we define that? You know, we can talk about it in terms of, well, you know, there's a 5% chance or a 10% chance of something good or something bad happening. But even then, you know, how bad does it have to be before it's futile? Is a 5% chance of success enough, or a 1% chance, or a 0.5% chance? So, you know, there's a lot of question around that. And we could look at what are we trying to do as well? Physiological. So, for example, with CPR, if we rush around and do CPR, well, we may get the heart restarted again. Yippee, that's a pretty good start. But is that enough? And, you know, maybe it's about failure to stop death, you know, but again, what does that mean? You know, for half an hour, for a day, for a week, for a month, what are we talking about? I think the more important way to think about it is much more involved in that. Yes, numbers are important and we need to understand that, but it's more about the qualitative components as well. So it's also something about the failure to achieve an acceptable quality of life for the individual. Remembering that it's actually the individual that should judge the quality of life, not the healthcare provider or some other random person that we might choose. And so although a treatment may prolong life, it may still be inappropriate or not in the person's best interests. I think the other thing I often get asked about is, well, don't we have a duty of care as a doctor to keep people alive? And yes, we do. So I actually quite like this quote from Lone Skeen at the University of Melbourne. So the doctor's duty of care, or you could actually substitute a healthcare provider's duty of care, is to take reasonable steps, as other reasonable doctors would be, you could argue what that means, but to save or prolong life or to act in the patient's best interest. So it's not all just about prolonging life. The other thing that I think we do need to talk about as healthcare professionals, and probably as a population, is around distributive justice. We all know healthcare resources are finite. I think we all have a responsibility to think about this and to think about how we manage these resources because they are important priorities. And I think if we don't get on the bandwagon and do this, somebody else is going to do it for us. And I think as healthcare professionals, we're in a very good position to recognise this. It doesn't mean that that's the first thing we think about when we've got the patient in front of us, but I think we do still have a responsibility. I think the other problem we face is that death and dying, and even the limitations of modern medicine, aren't, and perhaps how we utilise resources, aren't particularly discussed in the public arena. They're certainly not overly discussed in the political arena. And I think some of these things need to change because our patients probably get this more than we give them credit for. You know, they know things are expensive. It doesn't mean they don't want it, and it doesn't mean they shouldn't have it. But I think it is okay to at least consider these things at some level.
That was fascinating. So that pretty much draws to a conclusion both meetings for today, the Australasian launch of the Global Tracheostomy Collaborative and also the International Tracheostomy Symposium. I'd like to invite David up to the stage, and what we might do, we've got time, so if there are any questions, I'd like you to stand up and yell out as loud as you can if you can't get to a microphone. But it's also an opportunity to ask questions of some of those speakers where we didn't have time. And I'm sure they wouldn't mind coming towards the front and answering any questions if anyone had any questions that they weren't able to ask at the time. So, has anybody got any questions from today? They've all been asked?
I have a question. Besides Hatham and me and Michael, and I met, how many ENTs in the audience? Excellent, great. Okay, come find me during cocktail hour.
Fantastic. So, if there aren't any questions, this concludes the meeting. I'll hand over to Tanis for the formal aspect of that, and I'd like to thank everybody for hanging in there to the end. I think it's been an absolutely brilliant meeting. Both meetings have been absolutely brilliant, and hopefully we all leave here inspired and can apply some of the things that we're aiming to do, which is collaborate, innovate and excel.
Thank you so much, everybody. I hope it was, I found it an inspiring day. We had so many great speakers, so many people willing to go the distance in terms of a huge amount of work. So thank you to all the speakers, to all the organizing committees, to our receptionists who have done an unbelievable job in organizing things. And at this point, it's my very great pleasure to say, David, come up here. And on the part of the GTC Steering Committee, I'd like to say congratulations. It's massive. David has organized 3 GTC kickoffs in 1 year. Having done one, I can tell you his stamina is pretty good. So congratulations on the part of the GTC for completing that. Everybody will receive momentarily a survey monkey for your feedback on this meeting, and we'd love you to complete it, so thank you for that. And please join us in the foyer for a cocktail reception. You've been a tremendous audience, and all the best. If anybody would like to fill out or even just go to the GTC desk, we do have a packet called Let's Start. It's an activation packet. It has many of the documents that you would need to fill out if you're interested in taking back to your center about joining the GTC. So if you'd like to take one of those activation packages with you, please do. We didn't have one for everybody, but if you're really interested, please pick one up. So thanks again. All the best.